person, but hopefully in the coming days or next year, we will be all together. So basically, I have been asked to give a presentation with regards to diabetic neuropathy as a major risk factor of the diabetic foot. So basically, as an overview, we know that somewhere in the world, every 20 seconds, someone is losing his limbs. The impact of diabetes-related complications and amputations is obviously huge, not only on the patient, but also on their families and on the society. The impact of the quality of life on the individual is also massive. However, we do know that amputations could be prevented, even as we have already been hearing this morning other speakers talking about this, if we give prompt attention together as a multidisciplinary team. And obviously, the first most important thing is preventive measures like screening. So every person with diabetes should receive annual checkups with regards to screening in order to identify foot pathologies, deformities, all the risk factors which we have been hearing again this morning with regards to the foot at risk of ulcerations or amputations. So basically, we do know that the risks for diabetic foot complications are peripheral vascular disease, neuropathy, biomechanical alterations, poor glycemic control, cigarette smoking, diabetic nephropathy, and even people who have had previous ulcerations and amputations. But as I said today, with regards to this presentation, I will be focusing on peripheral neuropathy. So we know that diabetic peripheral neuropathy is an important risk factor which contributes to morbidity in diabetes. We know that evidence indicates that early detection of diabetic neuropathy will result in fewer amputations. However, although we know that there are different modalities which one can use, especially at the primary care clinics at the screening levels, in order to diagnose peripheral neuropathy, we do know that there are conflicting results with regards to which tool is more reliable, which tool is more sensitive to pick up neuropathy at a very, very early stage. So usually people with peripheral neuropathy present to the podiatrists or other healthcare professionals complaining of either numbness or tingling in the hands or feet, feeling like wearing a tight sock or glove around their foot. There could be muscle weakness. Patients could also maybe report the regular dropping of objects from their hands. They could report sharp pains in their hands, arms, legs, and feet. And they could also report a buzzing feeling sensation that feels like a mild electrical current through their hands or feet. Obviously, when a patient comes to us as a healthcare professional complaining of one or more of these symptoms, we need to obviously start our screening and testing in order to obviously confirm or otherwise peripheral neuropathy. So here, as you see in this slide, peripheral neuropathy, obviously, like all other conditions, will go through different stages. Okay, you will have the early stages when basically there will be no signs and symptoms. But again, this could be picked up even from early screening, okay, although the patient does not report of signs or symptoms. Then we have stage 2, where obviously, as I was talking before, people could present with different comorbidities. And then we have stage 3, when unfortunately, here we have late complications of clinical neuropathy. Patients might already present with foot ulcerations. We might already have a neuropathic deformity, especially Charcot joints and Charcot foot. And the patient might also present with non-traumatic amputations. So basically, again, as I said, it is very important that even when patients come to us, we need to categorize our patients, see which stage the stages of neuropathy is, in order to tailor both our treatment, our care, and even with regards to visits when we need to see how regular we need to see these patients in our clinics. So basically, this is just a brief algorithm with regards to screening and diagnosis of diabetic neuropathy in clinical practice. So obviously, we know that all patients with diabetes should at least be screened once a year for diabetic neuropathy. Okay, if during their testing we are quite happy with the results, then we need to follow them up every year, because we do know, as I'm going to explain later on, that these patients deteriorate very quickly. Then obviously, if our results are abnormal during our screening, we need to go for more intensive testing, like nerve conduction testing, which I'm going to be speaking later on in my slide. Very, very important that we really need to determine whether the neuropathy is actually coming because of the diabetes, or obviously neuropathy could be coming due to other conditions. So very, very important that we need to determine that. So with regards to the clinical pathway, as I said, even with regards to the speaker before me, this was already mentioned. So it is recommended that all patients with diabetic neuropathy, type 2 patients especially, should be tested every year. And as much as possible. Tests which could be used could include pinprick, temperature, sensations, ankle reflex, vibration perception, pressure sensation using the 10-gram monofilament. Obviously, combining more than one of these tests could help detect diabetic peripheral neuropathy, because we know that patients having any history of neuropathic systems obviously could be more prevalent to certain tests than to others. And basically, these are the most common tests which one uses in the primary care with regards to screening for peripheral neuropathy. We have the 10-gram monofilament, vibration testing, as I mentioned, the tuning fork, and the biotensiometer. And a few years ago, we did conduct a study with regards to the use of all these different types of clinical tests for screening at a primary care level. And we did find very interesting results, which I think the healthcare professionals, as people screening for diabetic neuropathy, should be made aware of. So the aim of the study was to compare different screening modalities. We conducted a prospective, non-experimental, comparative study. We had 100 patients who had been living with diabetes for at least 10 years. We used convenient sampling to recruit these patients, and for analysis, we had 200 limbs. Basically, we invited male and female aged between 40 and 80 years old, as I said, diagnosed with type 2 diabetes according to the WHO criteria. We wanted to exclude patients with type 1, as I said, patients who presented with other neurological problems other than neuropathy. We excluded people who had a history of neurological conditions such as nerve root compressions, patients with hypothyroidism, pernicious anemia, alcoholism, patients who had also liver disease, and patients who were using drugs which we know could cause neuropathy. So basically, we really wanted those people with neuropathy with type 2 diabetes. As I already mentioned, these were the tools which we compared, and obviously all tools were used according to the standard protocol on how to use the tuning fork, the neurotensiometer, and the vibratip. Basically, we conducted the chi-square test, where the null hypothesis specified that there was no association between the categorical variables and was accepted if the p-value exceeded the 0.05 level of significance. So basically, in our study, we had 57 males and 43 females with a mean age of 72 years, and these people had been living with diabetes for approximately 19 years. Their mean weight was 77 kilos and they had a BMI of 29. And this study did show that the percentage of participants differed with regards to which tool we used with regards to peripheral neuropathy. And maybe this presentation is clearer for one to understand, okay? So one can see that when we were using one specific tool, if we take the vibratip, 71% of people did actually feel the vibratip, but we had 28% who did not. If we come to the tuning fork, 88% felt the tuning fork, 12% did not. So you can see here that although we were using different tools to test for neuropathy on the same persons, different tools gave different results. And obviously, this is a bit worrying. So we need to be a bit careful here, because obviously, depending on which tool we are using, we are going to get specific results. So this study demonstrated that some tools maybe could be more sensitive to vibration perception than others. Then we recommend that different modalities should be used in patients with diabetes when we are testing for peripheral neuropathy. And obviously, when the results do not concur, do not agree with each other, then obviously we need to address this problem and use more sensitive tools in order to actually determine whether our patients does really have peripheral neuropathy or not. This obviously would help us as much as possible falsely identify patients who do not have peripheral neuropathy. And obviously, if we do not identify them, we are denying them the benefit of their effective care. So it's very important, I think, that with regards to healthcare professionals, we need to undergo a paradigm shift on how to screen for neuropathy. As I said, this is an emergency. We need to screen with different tools. And as I said, when we think that maybe there is something which is not really clear, then we need to go for other tests, okay? So we know that, as I said, diabetic peripheral neuropathy is indeed a serious complication of diabetes. Basically, as the speaker before me said, it is caused by high levels of blood glucose damaging the nerves. It affects more than half of people with diabetes, so hence why the importance of screening for this condition. Diabetic neuropathy reduces the ability to sense, which is, if severe, it makes people unaware of injuries in their feet. And again, the importance of education here to all our people with diabetes, with regards to them having to look at their feet every day to make sure that there are no injuries in their feet, because there could be injuries, but however, due to neuropathy, they do not feel them. It may lead to poor balance, and unless it's monitored, it's going to get worse. The resultant loss in feeling make it, as I said, very difficult to notice injuries. What could start with a very small skin irritation in these patients would very, very, very quickly develop into a complication. So obviously, without careful assessment and accurate monitoring and timely intervention, diabetic neuropathy will worsen over time. And the keys are to controlling diabetic neuropathy and its harmful effects, obviously, is early detection, as I already mentioned, okay, taking care of the feet, advising our patients to visit specialists such as podiatrists, neurologists, okay, as often and as early as possible, especially if they are living with diabetes. So, as I said, what can happen if it is untreated? Obviously, these patients could experience pain. These patients will experience small falls, and these patients will experience, obviously, the most important thing, foot ulcerations, which then would obviously lead to amputations. And one thing also, which I think we tend to maybe not mention a lot. We talk about risk factors, we talk about early intervention, but I think something which is today is a very hot topic with regards to depression. We need to be very careful because we know from studies which we have conducted that patients with peripheral neuropathy tend to suffer from depressive symptoms. And actually, this is a very recent paper which we published last year, where we looked at patients with and without diabetic peripheral neuropathy, and we screened them for depressive symptoms. And basically, in our study, okay, for those of you who are interested, this paper is available online, but if you can't download it, please do contact us and we can send you the whole paper. We did find an association between diabetic neuropathy and depression when compared, as I said, to patients with no complications. Therefore, it is very important then that when patients come to us, okay, we do not only focus maybe, as I said, with regards to diabetic neuropathy, whether there are early signs, as I said, of ulcerations, but we also need to factor this condition, the condition of depression, which we know is a growing concern too in our patients. And obviously, if we do find that these patients already have depressive symptoms, obviously we need to refer them to the appropriate healthcare professionals so that we can also start their treatment immediately. So as I said, the proper diagnosis of diabetic neuropathy is extremely crucial if we want to avoid future complications, comorbidities, okay? Current research and diabetic foot assessment guidelines lack to identify, okay, which are the best modalities with regards to vibration perception, okay? So as I said, we need to use different modalities. Here I am showing you a picture of a DPN check, okay? This is a nerve conduction testing. This is one of our latest tools which we have acquired at our university. And basically we are conducting studies using this tool, which is considered a gold standard tool, especially for primary care clinical assessments. We are comparing this DPN check to other screening tools which we usually use in our clinics. Okay, as I said, the expected rate of neuropathy approaches 50% in all our patients, but it is also usually could be sometimes missed when we use our traditional detection methods, as I have shown you in our previous study, okay? So even basically the compliance rate for the performance of the other tests, they could be basically low. We know that sural nerve conduction testing has shown higher diagnostic sensitivity with regards to even different stages of diabetic neuropathy. So, and basically, this is what the DPN check reports. It shows amplitude and conduction velocity. This is how basically the two readings are interpreted with regards to results. I hope hopefully next year, if we meet again in this conference, I will be able to give you the results of this tool, which, as I said, we have acquired, and maybe give you more results with regards to how effective this tool is with regards to detecting peripheral neuropathy compared to our other traditional tools. So basically, as we said, one of the biggest fears of diabetic neuropathy is actually developing neuropathic ulcerations. Okay, again, it's very important for the clinician when you are treating wounds that we need to actually determine what type of wound are we looking at. So am I looking purely at a neuropathic wound? Am I looking at a neuroischemic wound? Am I looking at an ischemic wound? Because obviously, depending on the different types of wounds that I am looking at, this will determine my treatment. And obviously, if I am looking at an ischemic wound, I cannot give the same treatment if I am looking at a purely neuropathic wound. So here, the podiatrist or the healthcare professional needs to be very careful and needs to determine what kind of wound we are presented with prior to obviously giving our treatment and to our advice. So, as I said, this is one of the biggest complications with regards to neuropathy. Okay, symptoms of neuropathic ulcerations. The base of the neuropathic ulcerations are usually reddish in color. The wounds will be well defined, punched out. Usually there is surrounding callus to these ulcerations. There could be undermining in the wounds, pockets on infections, which in turn could then later lead to also osteomyelitis if left untreated. The combination of pressure-related ischemia and neuropathy can allow obviously infection to escalate if they are not treated. When we are looking at a purely neuropathic ulceration, the wound is usually painless, unless obviously there is, as I said, infection or an arterial complication also with it. The limb usually maintains normal, obviously, pulsation, okay, because when we are looking at a purely neuropathic foot and the purely neuropathic ulceration, usually the circulation remains intact. So basically you could have a patient who is neuropathic, but upon Doppler assessment, his waveforms will still be triphasic in nature. Okay, so there I will know that I am looking at a purely neuropathic ulceration. And basically, these are some diagrams in order to show you what these are some of our patients' purely neuropathic ulcerations look like. And here again, in this diagram, we have a bit of a difference with regards to the presentation of a purely neuropathic ulcer, a neuroischemic ulcer, and an ischemic ulcer. And that is why I said it is very important that the first thing that a healthcare professional, a podiatrist, should do is to determine, okay, what type of ulcer I am looking at. And this can only be achieved through thorough screening, as I mentioned before. As I said, this presentation focused on screening for neuropathy, but my previous speakers also spoke with regards to the screening also for PAD. So one of the most essential components to effectively healing neuropathic ulcer is reduction of pressure from that area. Again, previous speakers spoke about total contact cast, therapeutic shoes, okay, the importance that we need to obviously know about these things and encourage patients, especially to wear therapeutic shoes. Okay, they need to be referred again to specialists in clinical biomechanics who know exactly the function of the foot and can prescribe a proper therapeutic shoe with a proper orthotic, which will offload the particular area which we want to offload to ensure that that ulcer closes, but also to ensure using specific tools that when we are offloading one particular area, we are not loading another area and thus could be the cause of presenting with a new ulceration. So here again, it is very important that our patients are referred to these specialists who know exactly what to look out and to how to look carefully after our patients. So as I said, wound management, offloading, debridement, as I said, these were mentioned all before, treat infection, the importance of proper nutrition, okay, pain management, manage edema, And maybe, especially, we could even want to use adjunct therapy like hyperbaric oxygen in order to try to close the wound as quickly as possible. We do know that one severe complication of Charcot-Foot, of diabetic peripheral neuropathy, is Charcot-Foot. So again, as healthcare professionals, we need to look out for this. Unfortunately, we do know, even from our colleagues and doctors and at A&D, we are told that sometimes Charcot-Foot is unfortunately not diagnosed correctly and could easily be misdiagnosed for a foot sprain or for an injury, okay? But we know that obviously this could be very dangerous, because unless Charcot-Foot is really diagnosed at its very, very, very early stages, okay, we could it could bring about severe complications, okay? Let us not also forget the importance of using thermography. We know that this is an innovative tool which is coming into our clinics, okay? More of our vascular surgeons in Malta are now using the use of thermography, and also podiatrists, okay, in order to try to detect, okay, the difference, as you can see there in the Charcot-Foot, okay, with regards to early detection of Charcot. So I said, Charcot-Foot is a medical emergency. It is often misdiagnosed during its acute stages, and it leads to irreversible joint destruction. So very important, timely intervention. As I mentioned again, good offloading measures is very, very, very crucial in this type of complication, as I said, if we want to avoid and ultimately, unfortunately, even, because we do know that most of our patients, basically after a year and a half of a major amputation, most of these patients die. This is confirmed by our vascular surgeon, okay? So it's very important with regards to the role of the podiatrist as part of the multidisciplinary team. We are here to try to save very important limbs and lives. We do have research to suggest that 45 to 85% less amputations have occurred when there was a good team approach, as again, as speakers before me has said this, okay? Very, very important that we need to work together as a team. And the team should include diabetologists, special nurses, vascular surgeons, the patient himself, family members, all working together, as I said, in order to try to save limbs. I thank you very much for your attention, and if there are any questions, I will gladly answer them.